Just one
Very
sec
good,
here.
Nan.
There you go. So I'm going to let a couple more people in, and then I'll go ahead and give my little opening and we can get started. Right. Good afternoon. I think it's afternoon there as well. Good afternoon. I'm Nan. I'm going to be your moderator for the ACHE Corporation. So your session host from the National Offices of the American College of Healthcare Executives. So glad to see you all. Before we get started, just a couple housekeeping tips. Following today's live session, we will ask you to log into the learning management system. And we will have the virtual recording of the event there and also ask you to complete the evaluation from today's event. I will also include a link directly in the chat. Today's session is worth 1.5 hours of face-to-face education credit. You'll need to be logged in for the entire 90 minutes in order to receive that full credit, and it will be applied to your ACHE account in approximately 2 weeks following the end of the session based on your live session attendance. At that point, you can view or print the certificate by navigating to the My Event section within the ache.org website. To ensure your participation is recorded for credit, please make sure your Zoom name matches the name on your event registration. Each live session will be recorded and also available in the learning management system in about 2 business days. For purposes of noise control, lines are muted for the duration of the session unless there's an active discussion. You do have the opportunity to submit texts or messages in the chat section, so feel free to use the chat if you'd like to ask anything. I think that's everything from me, so I'm now going to go ahead and introduce Jeff Guest, who will be moderating for you all today. And if you need anything, reach out to me in the chat privately, and I'll be happy to assist you there as well. Thank you.
Thank you so much, Nan, and welcome to our Friday NMHE-SAHA event. My name is Jeff Guest. I will be moderating for you all today. Pleased to be here, and thank you for taking time to join us. Today we have 3 panelists that are also going to be giving a brief introduction to basically the topic of today's section is COVID-19, what we learned, staffing, people, and resources. So kind of a human resources take on how we responded to COVID, and we're glad you're here to join us today. Our panelists today are Helen Nielsen, who's the Executive Director of Human Resources at UNM Medical Group, Correen Bales, who's the Director of Human Resources at Sandoval Regional Medical Center, and Barbara Deppman, who's an experienced consultant with over 40 years experience and a solo practitioner. I'll give a more detailed description of their bios at this point. Helen has recently joined UNM Medical Group as of June as the Executive Director for Human Resources. She has nearly 30 years of experience in human resources in a variety of industries, including telecommunications, construction, and healthcare. She has over 10 years of healthcare human resources experience and is a strategic business partner who values collaboration to achieve goals. Nielsen has improved metrics such as employee engagement, recruitment, and turnover. She has built a successful HR teams over the course of her career and is a trusted advisor and really enjoys mentoring others. She's a native New Mexican with roots in our community and has her bachelor's degree from UNM. She also studied law and public administration and has served as the board of directors for the American Red Cross and as a surveyor for the New Mexico Quality New Mexico organization. Helen was a finalist in 2019 for the SHRM New Mexico Human Resources Professional of the Year and is married with 4 children and 4 grandkids. Welcome, Helen. Additionally, we have Correen Bales with us today. Correen has been named the Director of Human Resources at New Mexico Sandoval Regional Medical Center in Rio Rancho, where she will assume the position permanently as of, actually, I guess that has already taken place. The bio said it was July 25th, so she's already in that role, and we're glad to have her there. She had been previously serving as the interim. She's from Corrales, New Mexico, and brings over 30 years of experience in healthcare-related human resource management from California, Arizona, and here in New Mexico as well. She previously led SRMC's Human Resources Department from 2011 to 2017, helping open the facility in 2012. She is a graduate of Northern Arizona University, and she's currently enrolled at Grand Canyon University, where she's getting a Master's of Science in Leadership. And thank you for joining us, Correen. Finally, we have, and not least, Barbara Deppman, who's joining us from Miami, Florida today. And thank you for joining us from all the way across the other side of the country. She is a FACHE with over 40 years of healthcare experience, starting her career originally in radiologic and ultrasound technology. Currently, she's a solo practitioner in consulting and provides direction for various clients on subject matters ranging from variance reduction, performance improvement, to building and expanding multiple outpatient centers and leading complex system-wide implementations and joint ventures. She was previously the executive director for a multi-specialty 100+ physician group comprised of diagnostic, vascular, and neurointerventionists. She also served as president of the South Florida Healthcare Executive Forum and the South Florida affiliation for the American College of Healthcare Executives. And there's more here, but it could go on, and it's quite lengthy. And needless to say, she has a tremendous amount of experience in a lot of different areas. We appreciate it. At this time, we'll go ahead and have Correen begin. Actually, I have just a brief introduction on the overall kind of structure to kind of set today's stage. Let me share my screen now. Can everybody see that? So again, today we're going to be talking about COVID-19 and kind of the human resources perspective. Panel focus today is really going to be kind of highlighting strategies and tactics of how the organizations and kind of the professional experiences that each of our panelists bring to how we've managed COVID-19 in this trying time, and understanding the events and decision-making that's gone on with that, in particular around kind of burnout and sort of staff morale, certainly quite important in terms of keeping people on task and being able to persevere in this time. And a lot of that has to do with communication models. Overall, the kind of from a quadruple aim perspective, there's been a lot of stories in the news, and I just kind of spent a little bit of time doing some background research and preparation for moderating today. And some of those interesting statistics, McKinsey basically indicated that over 60% of nurses are now saying they are floating between units, and certainly that has an impact in terms of their workflows and how much stress they're at capacity. And towards that end, 22% in this particular document ended up indicating that they may end up leaving their current position. Certainly that kind of burnout rate is probably understated in some sense. Overall, the literature search that this particular ACHE topic had presented talked a lot about structures and the importance of pre-planning overall and being able to leverage a systemness within our organizations. They really stressed the importance of having good flexibility and nimbleness of all of our people, and certainly the human resources departments really stressed that as well. The other key components is really communication and culture building as a whole. Building a sense of true resilience is absolutely critical. And like the Billy Joel song, it is a matter of trust. And it's really important that we begin to continue to build on those cultural aspects and maintain a sense of trust. And one of those areas, I know I'm a new employee at UNMH, having joined in the quality outcomes role, but Kate Becker, who is our president at UNMH, regularly talks about the importance right now in these trying times to extend grace to each other, and how that kind of communication, and I anticipate that our panelists today will be able to discuss a little bit more about those types of culture building opportunities. But ultimately, it does come down to workforce support, ensuring the physical health of all of our employees and managing that mental health and burnout considerations. And with that, I will go ahead and turn it over to Correen. Thank you.
Thank you, Jeff. I appreciate that. First, I'd like to just kind of start off a little bit and let you know about SRMC. So I'd like to start with the mission and values of who we are. So go ahead, next slide. So the first part of the sentence that we have here is really about improving the overall health of the community. And this truly navigates the course of SRMC. With our values, next slide. These values were put together by a group of employees before the hospital was up and running. And I could still see the room itself where we were at and putting these together. And what we also did with these values is we put key attributes in there, and then those key attributes roll up to our principal behaviors, which really is a human resource dream of putting a culture together. Next slide. And then we have a slogan of putting you first, which goes with making sure that we do everything that we can for the community that we provide. And so this slogan is really everything that SRMC strives for. Next slide. So as Jeff had said at the very beginning, we started to break ground in July of 2010. We saw our first patient in July of 2012, and I still remember that patient in the emergency room. They probably had every single healthcare worker that we had at the time doting over them. So it was a really cool experience. And we're really focused on the community, academics, and the specialty line services. Next slide. So how SRMC fits within UNM, this just kind of gives you an overview of where we are. So there's the University of New Mexico, then there's the Health Science Center, and then we have the clinical, the teaching, and the research, and then SRMC is underneath in the UNM health system, and we're part of a Research Park Act. So in that Research Park Act, we are an individual hospital as well. So we have our own 501c3, we have our own policies, we have our own hiring practices. So it's a little bit different than, say, a big health system like Lovelace or Presbyterian. Next slide. So currently SRMC is located in Rio Rancho. We have about 615 employees. We have a $47 million payroll. We have 60 beds. We have a fourth floor, a fifth floor, and an ICU, all private rooms with beautiful views. So the picture down below shows you a little bit when the patient is looking out and they see the sandias. So it creates a really nice healing environment. We have a 13-bay emergency department, which is expanding as we speak into 20 beds, 6 ORs and special procedures, radiology department that functions at full throttle. We have a medical specialty and infusion, and then we also attached to the hospital is a 40,000 square foot medical office building that houses like our primary care, surgical specialty care, that type of thing. And then we also have physical therapy. Next slide. These are just some of our recognitions that SRMC has received over the years since opening. And our last one, of course, is the US News and World Report. And just to kind of give you an example of how we celebrated that, the leader of our respiratory therapy department, just last night, we were able to participate with him as he honored his staff in all of the accomplishments that they did in order for SRMC to receive that award. And it was a pretty cool event. It was really nice to see. Next slide. And currently right now we are, if you ever have the opportunity to come out to where we are located, it's over by the Santa Ana Star Center, and you'll see a lot of construction that's happening at the front of the hospital. And this is what we consider, it's a Center of Excellence Orthopedic Surgery and Rehab building. And it will open in November of this year, and we are currently recruiting staff in order to open up the building. We have the director on board, we have our administrator on board, we have radiology on board. So it's kind of it's a cool time to watch it grow. So with the topic that we have at hand, have to, without our executive team, the hospital would not have done as well as it did through COVID. And by far, the leadership at SRMC is outstanding. And I get the pleasure of working with them every day. Jamie Silva Still is my boss, and she's an amazing lady and is very dedicated to her work. Everybody on the team really kind of has that servant leadership philosophy where they put others before themselves. And I think that has really made a huge difference with what happens in our organization. And just an example, Pam Demarest, our CNO, we had like 6 deaths in our ICU in a matter of a couple of days. And she's the first one to go down. She talks to the staff. She, provided food, but most of all, she was just there for them. And she really wanted them to understand that they're not alone. And most hospitals, I would say the majority of the hospitals have a hard time recruiting to their ICU because ICU nurses are burnt out. They don't want to do it anymore. And our ICU doesn't have that issue. We have some openings, but it's more for volumes rather than them being burnt out. And it has a lot to do with their leadership. So my hat's off to them. And then CEO Jamie, she does weekly town halls. She makes sure that everybody is informed, up to date. She tries to be as transparent as she possibly can. And then she allows for questions. So the staff can ask her questions every week, and they put them in the chat, or they'll say something while she's doing the presentation. And it's a really cool environment, and it's neat to watch and see. And while we were going through COVID, we didn't have any layoffs or furloughs. And that was a pretty cool thing to do as well. So they were able to deploy staff in other areas. And then, the rooms that we had in some of the rooms that we had in the hospitals, we kind of, for lack of a better word, called them veg rooms, where employees could just kind of go and decompress and not have to worry or think about what they had to do. They could just kind of let it go for a second. And then we implemented a hero bonus last year, where every employee received some type of compensation for all of the hard work that they did and for just kind of hanging in there with us. Supplies, we always communicated the supplies, made sure everybody understood that we weren't going to leave them hanging. And then working from home, and that was allowed for a short period of time. And I think that was also very helpful. Next slide. So that doesn't say we didn't have challenges, right? We had a lot of them. Travel companies were probably the biggest one. Those guys, I'll tell you, the cost of a traveler has absolutely doubled in the last year. And it's almost like they wait to see who's going to give them the most money. And hospitals are at a disadvantage because we need staff. So we're paying these astronomical amounts of money to bring staff in to help us with the volumes that we're seeing. And then, of course, the compassion fatigue, both with the compassion and burnout. So we've got both extremes happening at the same time. Compensation, as soon as you feel like you're maybe pretty close to what the market's doing, then the other hospitals within the surrounding areas increase their hourly wages, and it always feels like you're behind the 8 ball. And then working from home, Helen is going to, on her presentation, she's mastered this, and SRMC has not mastered this yet, but just kind of getting the staff back into the work environment was a little bit challenging. And then our federal pandemic unemployment programs, that created a lot of anxiety, and you can't drive down the street in Albuquerque without looking at a bunch of help wanted ads and posters and businesses wanting people to come back into the workforce. And that also affected the hospitals very much so. Next slide. So what we're doing, how we're responding, the well-being programs that we have, you have your typical EAP, but what we've also done in addition to that is what we call a telehealth. And that telehealth allows employees to call up within 24/7 at any time. It's very private, it's very personal. They can do it on their phone, they can do it at home, they can do it while they're driving home, and it's unlimited visits just to help them with some of the things that they're dealing with. And we also partnered with Salud Recruiting, which is they do Canadian RNs and they bring them into the United States. And so that's been a really successful program for us as well. Partnering with Workforce Solutions to help get people for like our hard to recruit positions, believe it or not, are like within the housekeeping, dietary, patient care techs, all of those areas. Temp positions for nursing students was a big deal, and our director of clinical education was really forward thinking in this and giving these students a place where they could get their clinicals and get some experience. So that's been a nice backfill for us as well. And then the incentives with the staff and implementing a new salary structure and equity program. I'm sure we're going to have to continuously look at that. We hired a talent acquisition guru, and she's a go-getter. She's been amazing to help get some staff into the hospital. And then we're currently exploring the working from home. So I'm excited to see what Helen has to say on her side and what we can learn from her. Next slide. We started a fast track hiring process and we implemented it a couple of weeks ago. And why we did it was because people, they're so far and few between to get people to apply for positions that we didn't want to lose them or have the opportunity that someone else would snag them up. So this allows us to really identify those highly qualified candidates and then make offers. Our goal is to make those offers within 24 hours or less. And then we've also implemented like an NEO every week. We used to do it once a month, then it became bi-weekly, and now we're doing it weekly. And we're experimenting with this through November 12th, just to see how successful that will be. And then we'll just kind of continue to monitor that. Next slide. So our priorities right now, obviously, are diversity and well-being for our staff, hiring, making sure that we get temp help to help with our patient care and the loads that are coming in and the volumes that are coming in. We also need to focus on our leadership development. I'm a firm believer that when you have the right leadership, the staff stay. And then assisting with the opening of the Orthopedic Center of Excellence. So that's really kind of what we're focusing on. Thank you, Jeff.
Thank you very much for that presentation, Correen. And next we have Helen Nielsen, Executive Director of Human Resources at UNM Medical Group. Helen?
Thank you, Jeff. It's going to be tough to follow Correen. Okay, so just a little bit about the medical group. We are part of the UNM health system as well. And really our existence is a little bit different. We're not on the acute care side. We are definitely a business arm for our School of Medicine, but we also have a clinical delivery system as well. We have several ambulatory clinics that we run. A lot of them are for very unique and special populations, but we also have some very special clinics and also primary care. So that first bullet really just kind of speaks to what we do provide and really being born out of a need to support our healthcare system. And we have around 600 employees and 97 open positions currently. So we're growing, and it is a fast track to try and get people on so we can fully support the health system. We are also independently formed under the Research Park Act. So we're a separate entity as well. We have our own board, we have our own FEIN number, and et cetera. So we're our own entity, and we have our own benefits and payroll and that kind of thing. We have a very diverse clinical practice. Like I said, we have primary care, and then we also have like our Center for Life, which is alternative medicine, such as acupuncture and massage and different things that we can supplement the ambulatory clinics with. And overall, we help the health system through our revenue cycle engine, which helps support the healthcare system. We also do a lot of hiring of what we call providers. And so it's not only physicians, but it could be APPs or NPs. And so we do the staffing for that. Next slide, please. This is an eye chart, but it is an org chart that I would like to just have you see. We are the medical group, but if you can see, we are very aligned and tied to the School of Medicine and really supporting their mission of the teaching and the faculty component. And so part of our mission is really to support that School of Medicine so that we can support the future of medicine in our community and really enabling providers to teach and to excel. And that is also through a lot of other mechanisms, such as billing and all those back offices things that a lot of folks really, when you think of healthcare, you don't really think of all that stuff, but that's a lot of what the medical group does. So over half of our population is more administrative in nature than clinical, although we do have a clinical arm as well. Next slide. So for COVID, I joined in June of 2020, but so COVID was already underway. And I think once it hit, I think there was two big themes that came out of what we want to accomplish. And it was safety and safety. And so safety for our employees going into the workspace and arming them with the things that we could, the masks, the PPE, and all of that. And then also the social distancing and all of those things that go into safety in the workplace. But then because we are such a heavily administrative function, we also were able to deploy over half of our employees to work from home. And so we came up with a tiered system at the onset and really kind of identified those who are clinical, those who are administrative that can work from home, and those that might have duties that we can put on the back burner for now, but then also maintain their employment. So it was safety for employees in the workplace, but also safety to keep your job. That was a very big focus of ours. We didn't want to have any layoffs. We knew other entities in the community were doing that or furloughing employees. And we stuck to our principle of not allowing that to happen. So we worked with our clinical operations to ensure that we looked at each job description and were able to parse out some of those administrative duties from the clinical job descriptions. So even some of our clinical folks were able to do some of their work from home. So we didn't have all of our employees in the work environment so that we could have that social distancing. We also, because we were ambulatory services, we were looking at our services and said, which ones do we really need and which ones can we close for now temporarily in order to stave off some of the pandemic. And then I'm going to highlight telehealth. That is something that is stemmed out of the medical group. And I have to give it up to Stetzenberg. He led us through that programming and it became this huge, robust beast, I would say, but it really took a life of its own and it was very successful. So we were able to get patients seen in a virtual way so that we could service and deliver healthcare for our community. And so that was huge. The other thing that really kind of was born out of this was the childcare issue. So we did have employees that really had a lot of focus on how am I going to take care of my children because they're not going to school. And so we got a list of resources trying to work with our community. We have a school-based health program as well. And so we worked with those entities to try and see what we could do for our employees with childcare issues and push that out. We worked with the health system to provide a COVID hotline to funnel questions to, and it really kind of led to a consistent practice of answering those COVID questions. And those were clinical folks manning that line. And it's still in existence today, unfortunately. But on the onset, I'm just going to say, we thought this is going to be a few months, and by the summer, we're all going to be back in the office. Well, we didn't know we're in it for the long haul, and it was a marathon. So we really needed to look up and say, what can we do for our employees more robustly? So we stood up in an employee support group to work through employee morale and issues. And so anything that came to that group, we worked through it as a team. So it wasn't just HR, it was operations, it was strategic planning. There were some clinical folks on the team, behavioral health. And so we were able to really kind of talk through these issues and then come up with some planning around how to support our employees. And I'm really happy to say we also did not have, in the end, any layoffs or furloughs. Next slide, please. So work from home was a thing that we implemented right away. And people, they were carting out their chairs and their computers, and they were trying to get their stuff to go work from home. And we determined back in around August of 2020, okay, I think work from home is going to be here to stay, especially for our administrative folks. Next slide, please. So we really had some guiding principles on the work from home. We wanted to ensure that we had a COVID safe environment. We wanted to also bring in kindness into the mix and making sure that we now understand it's a marathon. It's not this short-term pandemic that, a lot of our leaders are emergency care providers. And so they're used to that quick, emergency room type of service. And so we have to stay in that mode long-term. And so that was a shift in our thinking, and really continue to closely monitor our productivity and our financial performance. Healthcare, it is a very service-oriented thing, but we also have to pay attention to our margins, right? No margins, no mission. And so we really looked at that and said, how can we work from home but also ensure that we're being productive? And so, but then we also know that those of us that work from home, you can have back-to-back meetings from 8 to 5, and you get maybe a few minutes here and there to get up and maybe have a bite to eat or have a drink of water or what have you. So we put in some parameters. Try not to schedule meetings before 8 or after 5, or block your noon hour. And so we wanted to ensure that our resilience was still there, because it was that marathon mentality. And so we talked about the communication, and we did weekly town halls. We had a daily emergency operations group meet, and we did all team huddles. We did manager supervisors meetings, and that manager supervisor meeting was very critical because we wanted to give them information that they could then cascade down to their teams. And so we tried to arm our managers with information because they were getting bombarded by their teams. And so we wanted to enable them to answer those questions. And we wanted to make sure that we had good company issued equipment, proper equipment. People were working on their home computers and different things. So I'm sure IT's antennas were going up. And so we wanted to make sure that we had proper equipment. And then really encouraging employees to take PTO and not feeling guilty. Although I know there was a lot of that because you didn't want to leave your coworker hanging, because we all were short-staffed as well. So there was that dynamic happening as well. So next slide, please. So our approach, so most of our employees who are not patient-facing have expressed a strong desire to maintain the work from home. So we were willing to support that more permanent work from home state. And really also it helped us with talent recruitment and acquisition and retention with new people coming on board. That was kind of a lure for some people. And so we really asked all departments to go through a process of what does work from home look like for your departments? And we left it up to each leader to give us that feedback. Is it that all your department's going to work from home? Is it that a percentage of it? What positions in your organization can work from home? What positions are going to be in the office or at the clinics 100%? And so we came up with a construct of the buckets of employees and where they fit. And then we really combed through all our policies and processes to ensure that they aligned with our work from home philosophy. And we've been rolling that out to leadership and staff in a cascaded manner. And so that, because a lot of people were like, I really want to stay at work from home. I am finding it to be more productive. I'm able to contribute. And so we wanted to alleviate any kind of question around, is this just for COVID or is it going to be long-term? And we've settled on the idea that it is here to stay. We're not going back. And so we were able to bring a lot of processes into that so that it is here to stay. Next slide, please. On the recruitment front, I echo what Correen was saying. Recruitment is always very difficult in normal circumstances. Well, this was a very tough year because we saw a lot of people getting out of healthcare or not wanting to enter the healthcare workforce. So, the work from home option was helpful for us. We also implemented some new tools. We got a new applicant tracking system that really showed some ease of use for our applicants and for our leaders to really kind of track where people are in the system and really kind of have more of an efficiency in the process. And looking at how do we utilize our tools and look at what we call SEO verbiage for posting. So looking at our job postings and making sure that there's a lot of scraping being done, and so that our job has a lot of reach and to other entities to get our postings out there. We also have been very mindful on compensation as a healthcare system. We did also align on that new salary structure to be more competitive, but it's going to be also something that we do every year because we see that is a moving target in our market. And really looking at real-time equity reviews when we have new hires so that we don't impact our tenured employees. And then also looking at our diversity and inclusion dynamics and ensuring that we're not inadvertently harming anyone with salary. So looking at that as well. We did also hire a talent acquisitions expert and someone that has really hit the ground running, and I call her a hunter. She will go out and source. She will go out and cold call when we have, a high level position or just a hard to fill. She will find that person. And so you really have to go after those ones that aren't looking and try and recruit them. And we did pull more resources into recruitment than we had before. So we have others to support recruitment and look at how we can fill our jobs. And then empowering the hiring manager to have that system access, and then really acting on all your candidates timely. I can't stress that enough as for any leader. If you get a candidate, get with them quickly because they're going fast. And I've noticed that sometimes by the time we get to them, they're already hired somewhere else. So just a word to the wise, if you get a candidate, act on them fast. Next slide, please. So retention, really kind of transforming our culture into, leading with humility, having that servant-mindedness around, giving people grace and not looking for those gotcha moments or what have you. Mistakes are going to be made. It's a very stressful time, but looking at the process instead of the person, and how can we ensure that things are getting better and learning from our mistakes and embracing them to a certain extent. And then, monitor our compensation activities in the market and making sure that we're being competitive, listen and collaborate, and really focus on recruitment. So we're not, working short-staffed, and we don't have to, if we are working short-staffed, we don't do so for long. We do have a rounding tool in place where we round on every employee monthly, focus on stay interview questions, questions where we, what brings you to work every day? So we can really capitalize on that re-recruitment or retention focus. And, conducting exit surveys. Why are people leaving? Is it the job itself? Is it something else that we can impact? And then, going in and conducting climate surveys where we see some high turnover. And so that has been something that has borne some fruit as well. And so there's been also a lot of communication plans put in place and different things. So just a lot of work surrounding this, and a lot of good employees putting in a lot of time and effort to making sure that our organization is staying on the cutting edge of this pandemic. And my last slide is, while a lot of healthcare entities went down in employee engagement, I'm really happy to report that at the medical group, we improved our employee engagement by a substantial amount. And so that was a big celebration for us. It was a big win. And so we did our engagement survey in the spring of 2021. And I think all of us were holding our breath because it was such a rough year, but it was so nice to see that we really rallied around our employees, and they recognized us for it. So that was a nice way to see that come to fruition. Next slide. Oh, thank you.
Very good. Thank you so much for that, Helen. And last but not least, we have Barbara Deppman to add a consulting viewpoint on all of this.
So hi, everyone. So actually, I had spoken with the team, and I had thought that it would be really great to perhaps even separate my presentation out from two perspectives. Number one is from a radiology perspective, what did a very high technology field do during this time, and exactly what were the best practices that were pursued during it. And then the second one is me as a consultant, you know, how was I able to navigate through the year that was, you know, out of the ordinary, as we all know. So, and it's continuing. So how do you best do that? There's a lot of students that have reached out to me in the past across all ACHE, you know, wanting to be a consultant, but I just want to make sure that, you know, they understood everything that is going to be expected of them and how to navigate best through these waters as these issues occur. So while we did have the pandemic, you know, obviously global, but Miami, really the essence of it all is with the hurricanes, Louisiana, you know, a lot of the catastrophic weather issues that we've had across. So these things happened, and things just totally happened out of the ordinary. So in radiology, obviously, they did a lot of, you know, the elective surgeries and procedures and exams. They were deferred. And so what do you do with the staffing? Because we definitely did not want to neither lay off nor furlough. And the difference is in radiology, just like a lot of the other ologies, the staffing is also subspecialized. So how do you do this? Because you can't honestly just do an ultrasound technologist and put them in an MRI scanner. That just doesn't happen. So the reality is that what we ended up doing is, aside from the fact of cross training, we actually, a lot of the hospitals I worked with actually paid it's generally, it's not a true nominal fee, but it's not that over beyond for a lot of these technologists to go through the actual formal subspecialty training, and then they can sit for the certification board. Then this way you probably can get all the radiology. So the CT can perhaps do an MRI, MRI can do mammography, all you know, true cross train. And we went ahead and we paid for it, because at the end of the day, if you have an excellent employee, it would make sense just to retain them, give them that extra markability, and at the same time, they're already well founded in your culture and you do not have to recruit. But then right when the pandemic happened, we would have a lot of the technologists, they would be the ones that in, you know, welcoming patients, taking the temperatures, doing all kinds of things, because a lot of the rooms, you know, they were either being closed just because of lack of volume, or they were getting the negative pressure installation and everything having to do with that. So it was a time of great creativity, and I can honestly tell you that the staff really appreciated the fact that they were able to work, because a lot of these individuals really cannot work from home because they're patient facing. And so, and then for us, it's very costly, because obviously to see a patient, to do an exam, it's not a stethoscope that costs what, $30, $40. It's a $2 million scanner that's just sitting there idle. So we were trying to do all kinds of things just to keep it going somewhat. Another thing that really transpired in our industry is a lot of the mobile technology. So we were doing mobile CTs, even now mobile MRIs, mobile X-rays, ultrasounds, point of care testing. In the different rooms, we were able to do that as well. So, and these devices generally emit less radiation, so you can have them in fairly large rooms. So that's not a problem. Then huddles, what we would do also is, just like everyone else, we did the huddles. A lot of times we did 2 huddles in the morning and the afternoon, because a lot of these staff, because other ones couldn't come in, or for whatever reason, they were all pulling 12-hour shifts, which is exceedingly stressful, and it's a burnout. So we wanted to always make sure that the administrative team was always on hand for them. And, we always made sure that we support the administrative team as well, because, you have to support the support. So, so that was interesting. Also in radiology, you had then much more of the telehealth or the telemedicine or teleradiology. So that was really interesting, because now you're paying for $20,000, $30,000 monitors just to do the high-end tech radiology procedures, and then teaching the older than millennial ones how to really navigate around and make their environment at home easier for them to read, because they have to have a certain amount of light in the background, and it cannot be too bright, and obviously it cannot be too dark, because it would be a strain in the eyes. So that was very interesting too. And so from that perspective, budgetary constraints had to be lifted, because we still needed to provide patient care, and it had to be done from the home. And at this point, as you can see, there's a lot of teleradiologists out there. They're really taking advantage, and it's a great opportunity for them to provide, excellent care across the mile. So that worked out really well. Let's see, am I forgetting anything? No. So basically, from a technology perspective, one of the things you need to consider is, if you have great employees, go ahead and invest in having them cross-train and cross-specialize. They will, and they really will be loyal to you if you support them. Then now, so I'm sure if anybody has any questions, they will be answering questions at the end, and I'll be more than happy to help that. Then the second thing I wanted to talk about is from a personal perspective. So what do you do in consulting? Because I'm a solo practitioner. I do not work for a consulting firm. And even the ones that worked for a consulting firm, they did have a lot of layoffs, and they had a lot of furloughs. A lot of times hospitals, and my background is hospitals, so I can speak. I've got poetic license, because that is the bulk of my career has been in the hospital provider environment. And so basically, what would occur is, because of the layoff, because of the furlough, the reality is that that's when you really need more of the consultants. And a lot of hospitals think, well, no, we can do these things, we can implement, we can execute, we can do these performance improvements, we can do these efficiencies ourselves. Not necessarily, because the reality is the person that's doing this, it's already indoctrinated in that environment, and they're a lot less able to be objective. And though consulting can be a little expensive, on the other hand, you really have a return on investment, because those programs, those processes, whatever improvement you need, they really generally get addressed, and your deliverables are right there faster than if you were to do it internally with your own crew. So what I did a lot is, and this is something that I would recommend for everyone to do, is, start, thinking of things that you had thought about before in terms of experiences you had, and start publishing. Because if you put your name out there, you put your papers out there, LinkedIn is a great venue to do so. There's a lot of technical journals, Radiology Business Journal. They published 3 of my articles, and then they were republished to the American Imaging Association Journal. So people know your name. And then another thing is, if you're involved with any associations, obviously ACHE, but there's other ones as well. There's HR associations, there's finance associations, there's other MGMA, right? Physician Group Association. We have the RBMA, which is the radiology affiliate of the MGMA. Is really, now it's your turn to really support those associations, support those boards, because by you being there, you're really placing yourself out there and your name out there, and people will be more readily to know you much better. So consulting is not for the weak at heart, and it's not for the introverted individual. It really is not. Those would basically, a lot of them from the consulting perspective will go more towards the analytics piece, or more towards the really high-end technology, you know, the cloud industries, the artificial intelligence, the machine learning part, whereas they're really not that communicative with other individuals. So if you want to do consulting, just know, please, that you really will have to be out there, talk the talk, get the networking, and, you know, and volunteer a lot, because really, as you do this, it helps you at the end of the day, and it helps who you're volunteering for. Just one caveat, be very careful, because that can take up a lot of time as well. And if you're committed, it's very discouraging when you're not meeting the expectations of whatever board or whatever association you're working. So you've got to, there's a little bit of a balance there, because you don't want to disappoint other people and you don't want to disappoint yourself. So so if I can, you know, summarize from a consulting perspective, is put your name out there, publish as much as possible, because you'd be surprised. You sometimes you say, well, gee, they already know this. Well, maybe not from your perspective, they may not know this. So, and everybody has different experiences. You know, I have academic medical center, but I have critical access. Everybody has different issues. So, but what is the underlying denominator of everything, and everything that Correen has said, and everything that Helen is saying, and Jeff, is that communicate, communicate, communicate. And in even more so, very important in a COVID environment, is that to keep that communication 20, especially in a hospital, it's a 24/7 thing, because your staff from 11P to 7A need the same attention that your staff did from 7A to 3P. So I cannot stress communication in all different formats, especially when it's working from home. You know, there's still the chats, there's still excellent ways of communication. So I think that's, you know, I speak really fast, and I just wanted to kind of bring up the rear, but not just from frontline, you know, in terms of what to do with the technology and the staff, but also yourself. Okay, so you want to be a consultant, well, this is what you got to do. So I think that's it.
Thank you so much, Barbara. I know that's particularly useful for our university students that are in the SAHA element and kind of giving. I also was a consultant with PricewaterhouseCoopers, and I can certainly attest to the fact that it is not for the weak of heart, but healthcare in general is not for the weak of heart, and it is that service-minded leadership that all three of you guys demonstrate, and I do appreciate all of your contributions. That concludes the first half of today's section. We're now going to discuss kind of some panel questions, and then we'll open it up after I've got three questions to ask our panelists today. And then after that, we can, if you do have a particular question that you'd like to ask, we can unmute you, but you can also end up putting that into the dialogue box if you would. First question, we'll start with you, Correen. Describe the biggest challenge that you guys see with staffing and safety in the workforce.
So that's a loaded question. There's a lot out there. I would say the biggest challenge that we have is really competing with the travel companies and making sure that you have the adequate staff that you need, and making sure that they feel safe, that they feel like they're a part of something. And if there is any type of compassion fatigue or burnout, how do we retain and maybe deploy them someplace else? So maybe we take an ICU nurse and start looking at clinics or a different, avenue where they can utilize their skills and still be successful for themselves as well. And then making sure you have those resources out there for them when those type of situations do happen. So that's really, really important. And I agree with Barbara 110%. Communicate, communicate, communicate. And if you feel like you've done it enough, do it again. Because I think sometimes leaders feel like if they communicate it one time, then they've said it and everybody needs to understand it. And that's not reality. I mean, it takes 7 times for somebody to tell me something before it finally sinks in. So and I know I'm a little bit probably more dense than others, but you still need to really get out there and communicate it in a lot of different ways. Some people like to read, some people like to hear it verbally. So you got to be creative with that.
Great. Helen, do you have anything to add on that particular question?
I think just kind of going back to the communication point is exploring all types of opportunities to communicate and having that two-way communication. So we did a lot of polling. We created an inbox around, just getting some questions because, and also on the polling thing, making it anonymous, because sometimes people are like, I'm afraid to speak up. So just giving a lot of variation in your communication and opportunity for that two-way dialogue. And we do have a stoplight report type of activity as well, and really trying to be mindful about circling back to that and giving an update. And so closing the loop on your communication is really important too. So they know that you're not just letting it go in a black hole.
Absolutely. Barbara, from your consulting lens, is there additional insights that we should be mindful of?
Yeah, so basically, the experience I had is calming people's fears. I did a lot of work towards the earlier part of COVID to the mid-COVID with a big academic medical center in their interventional suites. And nothing is more scary, more concerning that a patient that you've been working on ended up being positive, testing positive, because then you have the whole trauma of then, cleaning the rooms, trying to get into, not all the rooms have negative air exchanges. And then what do you do with the staff? And that's when, for me, I always had, it was almost like a direct line of communication with I'm not going to say quite the EAP, because they had a EAP light, let's just say, but individuals that are trying to say the right thing. Once, we had the clinical go ahead with the staffing, the staff either got tested or what have you. And even if they were, just to make sure that they did have the support they really needed when something like this that you don't expect happens. And it happens a lot in the OR, and it happens, it's not a lot, but it can happen. And those are the ones, it's all patient facing, but that is really intimate when you're doing procedures. So I think is to assuage the fear as much as possible and get really trained, well-trained people that knows the right thing to say.
A little bit more in depth in terms of kind of that communicate message. Was there particular communication systems that you guys ended up implementing into your frontline staff and to suppliers? Correen, could you speak to that at all?
Sure. We had a management system that was already in place, and Jamie was really very good at it. So we would do an executive huddle, and we still do it. And then we do a management huddle, and this was on a daily basis. And then the managers would huddle with their staff, and you really start to get that back and forth feedback. And then along with the town halls and making sure that you round, and you round at all times, whether it's the weekend, the day, the night, and you get the feedback and you try to get a pulse of what's really going on. If we didn't do that, we wouldn't know half of the things that were happening with our staff, so that we could really be there and help support with the different things that they were going through, so that you just do it different ways. And then you do your daily communication with emails. I think most of the time people don't read their emails, but there are those that do. So you still, try to use that as your avenue and do the best that you can with all of the information so that everybody feels safe and they feel supported. Because if you don't do that, that's when you start to get people who are scared, right? And they feel like you're hiding something and you're not being transparent. So, yeah.
Assessing that fear cannot be overstated enough.
Mhm.
And certainly the way you described that was kind of from the inpatient side in the hospital setting. Helen, does it change very much in the medical group setting?
I think so. I mean, we didn't have a lot of face-to-face interaction, over 50% of our workforce is virtual. And so doing a lot of those platforms of town halls and all team huddles and those kinds of things, but also utilizing, having the frontline leaders having their own huddles and their own consistent methods of communicating out, and arming them with FAQs or on certain subjects that were very coming up, either on the vaccines or, I just think of that because that's most recent, but or this work from home platform, so that they have all these questions and answers and the scenarios. Although we try and solve for all of them, so there's always unique circumstances. So as soon as we get something new, we push, communicate that out of, this is another circumstance. So things were very dynamic and changing, and making sure that we're learning from those experiences and communicating that back out.
Highly, highly fluid. Barbara, do you have any other comments in this particular area?
No, actually, it's really great though when everybody is so much in keyed already with their phones, right? And with the text or what have you, that within reason, obviously from a confidential perspective, but you tend to now really invest in phones for them. And this is when you can actually capitalize the fact that we're such a, technologically driven society, and actually I wanted to kind of do a little bit of a deep dive on Steve just sent out a question, and I think it's excellent because I did see this a lot, and it's there are national stories of nurses quitting and then joining travel organizations where they can make 2 or 3 times the amount. How can a hospital compete with that sort of environment? Well, you can compete. I know you can't compete. It depends. It really depends on the employee. I mean, there's reams of case studies how employees really don't leave organizations because of pay. They leave because of management. So I think that if they are already well enculturated within your environment and they really trust their leads, right, their executive leads or their management leads or supervisory leads, then because the reality is that yes, you can jump to other organizations, but not always you're going to get the same safety environment that you have in the organization of origin. So this is something that I always try to also drive with my, more the younger patients, in the sense that they don't yet have families, whatever, so they have a little bit more of leeway, wiggle room. But it's one thing that I really always try to stress is like, don't always go for the grass is not always greener. So because especially in this really precarious environment with COVID. So.
Towards that end, in terms of building that trust, are there other programs or specifics that you guys are implementing in terms of managing staff morale? Correen?
I'm just going to echo Barbara. It really, I don't know that you do so much with your programs as you develop your leaders. If you have really good leaders, employees don't want to leave them. If you don't have good leaders and they feel like they're just getting beaten up every day that they go to work, then that's when they go to the travel companies, because they can at least get paid to get beat up, right? So you want to make sure that your leadership is really vested in the staff. And at my presentation, just a little thing of what our respiratory therapy director did with his staff and honoring them. And he gave them like a little pin that he went out and got himself. And they wore that so proudly. And it was because he was there for them. He recognized them, and they're not going to leave him. You know, it's that kind of thing. So, yeah.
Fantastic story. Helen, do you have any similar types of stories going on at the UNM Medical Group?
I just, want to echo that too, is really focus on your leaders and getting them the tools and when we onboard new leaders, let's do it thoughtfully so that they really can understand what they're coming into and how to understand the organization and how they fit in socially and culturally and all of that, so that they know how things work around here, and so that they can then cascade that down. And so I think that level of leadership is so important and so critical to a successful organization. And we need strength, and we need to build that benchmark so that when we have vacancies, we are able to pull up from our internal ranks and really looking at how can we create that career opportunity for people. So that's definitely one aspect. The other piece is any decision making that you do have, think of it from how can I favor the employee in the best possible way. And so not to be punitive, like we talk about, people going out and being travelers with other organizations because they're going to make more money or they're able to do it. Okay, but we're going to welcome you back when you want to come back, or if something like that, but we're not going to shun you for doing that. I know other organizations can do that, but we want to say, hey, go do it. We'll be here, or figure out a way to keep them on PRN or in some way to keep them active so that you have them close by when they want to come back.
Across all those consulting areas and kind of this anti-punitive culture that we really want to inculcate, have you seen any other best practices, Barbara, that you can share from a consulting perspective?
So what we're doing in for one of my associations is that, so this is the time to speak with the early and the mid-careers in terms of career path. And it's not that you're inadvertently trying to mislead them and put a carrot in front of them, but the reality is, because COVID is marathon, and so we've been now pretty much putting all processes in place to continue on with this marathon. So now it's basically also a time that you can support these early to mid-careers with, do they want a higher leadership career path? What kind of, reading do they need to do? What kind of resources? And I think from an organization, to have a well-rounded employee, you do need to support that as well. And so I think that now it's really the time to have, those great conversations with them, or if they're being not reading expectations as to the whys, right? And so now it's a little bit more of the time to be, and I have to say, because it's COVID and safety, but more touchy-feely, if nothing else from a psychological perspective, that they know that they're being supported. So it's like Stetson just says, give them a lot of swag. Absolutely, I'm with him 100%. It's
funny how at UNMH currently, I'm working on a project around pressure injuries, and we're trying to figure out how do we end up. But it is even small things like swag, even things like banners can end up having, it is in some sense recognition. It becomes huge, and being able to bring that forth, and we don't do enough of that. And it's one of those things, we just get so busy, and there's always those problems and I even noticed within the 4 or 5 months that I've been here, we are always having, because there's so much, but we don't, it is easy to get distracted from being able to do those celebrations. And it was one of those things that was reiterated regularly in terms of our training, in terms of just general good management practice. And we know this, but it is still very difficult to find the time to kind of incorporate that. Stetson did have, and you were discussing kind of the seeking, Stetson had a particular question that I think I'd like him to go ahead and ask. Stetson?
Yeah, I'm gonna hopefully not stir the pot too much with a couple questions and a statement. So I'll start with the statement. Hi everyone, I'm Stetson Berg. I'm the president of the New Mexico Healthcare Executives, and thank you Correen, Barbara, and Helen for coming. This has been absolutely wonderful. It's not over yet, but thank you. And Jeffrey for moderating. As someone who's taken advantage of a postgraduate fellowship, I wanted to encourage probably mostly Correen and Helen to consider adopting a fellowship at SRMC and UNM Medical Group. There's not a single one in the entire state, so any of the Masters of Healthcare Administration students would have to leave the state like I did, and likely won't come back. And so I want to encourage you to consider having one of those. There's many of the leading healthcare facilities in the country have them, and I cannot tell you hundreds for sure, depending on the organization, thousands of masters of students apply, and it really attracts talent. And so and there's also resources I can share with you later on how you might do that. And just for me, that looked like reporting to the CEO for an hour a month and then floating around to different departments. Others are staying in one department and working on a project for a year. So that's a shameless plug to consider a fellowship for students. And then I know that there's people on from NMHE that may be looking for jobs. I know those certainly be students looking for internships and potential jobs. And I don't know if I know at least Helen and Correen have web pages where you're hiring. Do you have any internships for anyone? And then also, where would they apply for a job if they wanted one? And Barbara, please chime in if you're going to be a team of two or what have you.
So I love your plug. I like new ways of doing stuff. So please, let's talk after this. Internships. So we have, our CNO has been very, I would say she really wants to look into the future for those type of things. So she's creating an internship program for nursing right now. And she is partnering with the different colleges along with our director of clinical education. So although we don't have it right here this moment, it is coming. And it's mostly in the clinical field. And I realize that you're on the administrative side, so I definitely would want to visit with you and learn more about that, because that's an amazing way to recruit. So thank you for that.
At the medical group on the internship side, we're looking at an internship right now for coders and coding. That's an area of opportunity for us. And then also on the MA side, how do we get, traditionally, we've always wanted MAs to be certified or have those higher levels of experience. But how do we capture folks right out of school and get them trained up and kind of grow your own programming? And I know nursing is the same way. When I was on the acute care side, we would do the same thing. How can we build those grow your own programs? And I think leadership is equally as important. So I'm really excited to hear more about how we can implement a fellowship as well and what we can do there. And I would be happy to send out our link on to how to apply to our positions. Like I said, we have 97 and almost 30 of those are providers. And so we need a lot of assistance and help, and we're constantly looking, and we have all types of roles. So I'll be happy to share that link too.
Thanks, ladies. I put SRMC's link in there, and Helen, if you get to it first, you might put MG's link in there, but I'm looking right now. So if anyone's just waiting, they can click.
I can say, coming from a Master's of Healthcare Administration program that had part of my graduation requirement was that I ended up doing an administrative residency for a year. And I can't overstate just how important that kind of tutelage and mentorship with a professional truly can end up being. I did mine with the vice president of quality for a 5-hospital system, and it just opens your eyes and it allows you to take what's going on in the classroom and apply it in more concrete ways. But it's also, ultimately, it is about exposure and getting an understanding of how those systems end up working. And even though you will end up after the end of that residency year, and I would be happy to discuss kind of ideas around that and bringing that here to New Mexico, because it does seem like we have a dearth of that type of availability here locally. And there is, we're well aware of the fact that there's a large standing brain drain going on with regards to the state, and true good talent tends to migrate elsewhere. And if we want to continue to be able to serve our patients in the way that they need to be served, we need to be able to retain that talent locally.
And one thing though that I have to, and I guess it's, you take care of your own, right? There's a lot of clinical individuals that want to do the crossover and become management, as part of their career path. And those are the essence are the ones that really are not able to do a fellowship because whether they have, family responsibilities, what have you, they cannot take a year off. And so one of the things that I really highly encourage that I always had in my department is those, in my case, it was the x-ray techs or the ultrasound techs, or, that they do want to jump over. And then you start giving them a little bit more leadership responsibilities and duties. And, because generally career path in my industry is, technologist to chief tech to supervisor to manager to director, and then you keep going. But then, I also got the bachelor's in BHA and then a master's in science and management. So, and then the fellowship. So, but the reality is not everybody can do that either, right? Because I was working full-time plus going to school. That was, talk about a brain drain. But I think within the hospital setting, if you can help them with whatever to help them cross over, minimal initially so they don't get overwhelmed, I think that would be really key. It's really a time to ask your employees, what do you need? It's like, it's such a hard thing to ask, especially when we're trying to keep patients out of ICU and alive, those that are in there. But really it's, what do you need? And what would you want? And that's very important.
Great points, Barbara. Thank you for that insight. Do we have any other, I don't know if there's any questions from our audience. If you would like to put something in the chat, or if you can unmute yourself and feel free to ask an additional question to our panelists. There was one additional.
What do you need?
Yeah, exactly. To that point.
You've got these two HR professionals.
There was
here.
one additional question that had kind of been identified earlier on by our panelists. Can you either anybody that's here today describe how your organizational policies and procedures stood up during this time of COVID? Were those policies and procedures related to staffing? Did they have to be adjusted greatly? Have they been, and are those adjustments, if there were adjustments, were those adjustments that are going to be longstanding and more permanent? Correen?
Well, so within the hospital, we stood up what is called the EOC or the HICS. It's an emergency management system. And you really have to follow that particular guideline and the process that goes with that. And your EOC kind of becomes the commander of the ship, and your staffing changes. So the governor shut down all of the surgical services, for example. And so making sure we could deploy the staff appropriately into different areas and making sure that we kept them whole. So of course, those policies and procedures changed. And then, like our rehab services, physical therapy, they're very, very highly trained. And how can we redeploy them into also other areas? So yeah, your policies and your staffing models change dramatically, and putting COVID patients in areas that didn't used to be COVID rooms, and then really trying to staff to what was coming in kind of becomes like a you know, that whole emergency management, it's not kind of, it is the emergency management process, and how you really restructure your hospital and restructure your staff and trying to do what your mission statement says and being out there for the community and doing what's right for your patient. SRMC was probably 80 to 90% COVID patients for most of the pandemic. So yeah, we really had to maneuver.
Wow.
In the southeast, we have a lot of hurricane readiness policies. And, you know, when you go to the watch and you go to the warning, well, to be honest with you, 2020 was almost like a hurricane watch the whole year round, because in some aspects you were still working as a skeleton crew. In some aspects you were definitely working, you know, now 24/7. So departments that were not. Just so we can stretch our resources as much as possible. So, so that's what I've seen more than anything, is this hurricane preparedness type of mentality, but all year round.
Jeffrey?
Yes, sir.
One comment that I want to share. I really appreciate the great presentations that we had today, and very, very helpful. I've been involved with the UNM-MHA program for a decade. And one of the things as I've been involved with in terms of New Mexico health executives is mentoring a lot of our students and graduates and others. A number of them end up deciding that they are not getting the support that they are needing, and they end up leaving New Mexico and going to other locations. And it's not just one organization, it happens in multiple organizations. And I try to provide feedback to them about how to address the issues before they make a decision, to talk with leadership and all of that. But I think that one of the things that we do need to look at, part of the reason the MHA program was started was to help address needs for person power, human power in meeting healthcare and the very diverse areas of our state, and particularly areas that are isolated. And I would just encourage everyone in human resources to continue that focus that we heard so clear today in terms of reaching out and recognizing that sometimes that the net result is people feel like, well, I've been working in this organization for 4 or 5 years, and they keep recruiting people from New York or California who stay for a year and then depart. And so just be aware of the fact that that is an ongoing issue, not for everyone, but there are significant areas where I think it is important. So thanks for letting me ask or make that comment.
Thank you, Ronald. That's all very good comments. One other question that Stephen Berkshire I know we're getting near the end of our time together here, but he asked, what are the lessons learned this past 18 months that will help us once the pandemic does finally subside? Or do we go back to how we managed before? Are there permanent changes that we think that are going to be long-standing with us out of this? Helen?
And if you can answer in a few sentences, we still have to leave a little bit of time for a ACHE moderator, Jeff. Thanks.
Yes.
Yeah, I'll be brief. I think this pandemic has shed a lot of light on how we can change our way of thinking. It's forced us to be very creative. It's forced us to get very close to our frontline staff and listen to them and provide the tools. They're the ones doing the work. It's not the x-ray machine or what have you, right? So we need to really look at them and listen to them and have them provide us really value added feedback. And so that's going to be a shift for us, is really how do we put that employee first so they can put the patient first?
It's, you know, how do we pursue the best practices and maintain them, right? So, so we escalated communication, we escalated a lot of, you know, we shortened a lot of processes that needed to be shortened. Well, perhaps we just need to keep those going because they really add a value add to our employees' life, right? So that's what I think, that just continue with the best practices you gleaned from the COVID pandemic.
Great. Well, at this time, I think that was a wonderful presentation. Correen, Helen, Barbara, thank you so much for your time today. We really appreciate it a lot. I know I learned a lot and very much enjoyed our hour and a half together. At this time, I'll turn it back to Nan so she can end up closing us out.
Hi, thanks everybody. Thanks, Jeff. It was a very good discussion. I was listening the whole time, and I want to thank the audience for the participation and also our panelists. It concludes our session now. The recording will post within about 48 hours or 2 business days. And I just have to give the disclaimer that today's program is copyrighted in 2021 by the American College of Healthcare Executives, so all rights are reserved. And I hope everyone has a great weekend and stays safe and healthy. And thank you.
Thank you all.